So, very good evening, sir, Dr. Manika Vasagam, for this platform to share my experiences in the 3 decades of my professional career, as well as the experiences what I have heard and seen through my ancestors, right, from my great-grandfather and so on. Anyway, I always take this as an opportunity to share this with the youngsters of our profession, mainly to tell them from where we have evolved and reached the present scenario. Having said that, can we ask the people to mute? Yeah, please. So now I wanted to always share this among the youngsters, not the experienced professionals, because I find as a educationist as well as a clinician, the recent saying among the youngsters that dentistry has got no scope, and they say that it needs a lot of other investments and so on and so forth. So I always make them understand where we are going wrong and how we can establish slowly and steadily, and how do you attain your vision. So that's why I thought I'll take this as my topic: established dental practice establishment and management. What to know before you start a practice. So it will be very short talk, which is just needed for a beginner to start the clinic, not for an experienced person, for which I have written a book. I'll show it in the last, others can go through that. The second talk, as you all know, that is more pertinent for an emergency management in a clinical situation. So that will be done by Dr. Reena John. Now, to start, I would give an overlay of what I would like to say today. Mainly our young dentists who passes out from the college should always know what their vision and mission should be. So my talk will be choice of the location of the dental practice, competition among our practitioners or our fellow colleagues, how much is the investment, design of your dental clinic setup, resources, what all you need, and infection control protocol and safety. Side by side, you should also know about the other jurisprudence and laws that we have to abide with. Clinical Establishment Act, GST and trade licenses, Consumer Forum and public litigations, professional and statutory membership, continuous professional development, public challenges and social relations, dental jurisprudence. So now what dentistry is exactly is not only about patient care. Everybody should understand that, the young graduates, but it involves a broader understanding of entrepreneurship, jurisprudence, the legislation, safety, infection control, and public management. So unless and until you really understand this and take it seriously, you will face a lot of problems and confusion and end up in a confused state. So before you start your practice, if you have decided to be a practitioner, you should have always a vision of what you wanted to be, what you wanted to achieve in a period of 10 years, or maybe what you wanted to be your destiny or at the end. So for which a mission should be always in place, where you'll have to draw a picture or an organogram. When you will reach this, how do you attain this, and what are the difficulties or challenges you'll have to cross, and that is why I have put this and included this in our talk. So vision should be individual choice, what you wanted to be a solo practitioner till the end, or you wanted to have become an entrepreneur with a consultant under you, with a multi-speciality dental wing, or you wanted to further go it as an hospital. It is all individual choice, and that is the vision. Mission is, again, you'll have to know where your certain challenges are there to accomplish that. That is what they call it as SWOT analysis. Every youngster should know what their strengths are, and individual strengths, what is their innate capabilities. And then their weaknesses also everybody should understand, and they should also know what is the opportunities that is ahead, where you are going to practice or what you are going to take it as a career. And then the threats surrounded for that vision what you have. So these are some of the things what normally strength means: individual professional skills, your soft skills, or you may be financially sound, you may be very popular there. So you may be in a place where you have a good social setup, or maybe you have got connectivity in the other groups of the organization. So that are all your strength. And in addition to that, individual skill of the profession is very, very important, not the degree certificate. So we should always understand that strength you should always assess, and therefore you should have to start your practice. And then the weaknesses, whether you have financial constraints, so plan it accordingly. What you wanted to invest in the equipments or your clinical setup, as well as your other weaknesses also you should know in your soft skills. So you better go get trained somewhere for some time immediately after getting the degree. Equip yourself and then start the practice. It's not that just because you have financial background and some amount of social background, you can start a clinic. That's not going to help, and that is where many of them end up in a confused state and they lose the interest. So you equip in the skill, and of course the knowledge is something which is assessing you by giving the certificate. Skill is something, it is your own passion. Then the opportunities, what you have, again, you know where your clinic is going to be set up, and area, and how is the socioeconomic strata ahead there, surrounding there, and what is your contact and what is your background. So these are all opportunities and threats. You should always see what is the number of dentists that is there on that area where you have decided to practice. So these are all the threats. So that is also something which you'll have to always see how to overcome that. Maybe the population there where the area where you are going to practice may not be highly socially sound. So there may be certain weaknesses, not that everybody can set up in a very good atmosphere or environment. So these are all the threats which you should always be planned ahead to face that in whatsoever you have your contacts or your ability. Now coming to the choice of the location, that's why I always tell my students also, do not think that only the urban area where the dentistry is sound or it is lucrative. Nowadays, fortunately, we have the road connectivity, even a rural area or a semi-rural area. So I always say everybody wanted to be in the urban area where they wanted to settle their life with the family and the children's schooling, as well as shopping and spending their weekends. This can be always done in a radius of around 30 kilometers from where you stay. So definitely you can reach a semi-urban or urban area where you can always commute yourself in the morning and back in the evening. So your other choices are also taken care of. Then you should always see about the visibility. So that is why I say, please select the semi-urban areas or maybe the rural areas. Now I see, I'm happy also to see many dentists are starting the practice in a rural setup where the connectivity of the surrounding villages are there, and therefore they are also doing very well. And fortunately the awareness is also coming up because of people like you, who like Dr. Manika Vasagam, who takes a initiation of creating an awareness. So I need many people to come ahead and create an awareness in addition to the association what we have. Then the visibility and signage, of course, for initial marketability, where you get popular, all the things which you all know, accessibility, and before starting or selecting a place, you should see the parking, where you can do the parking, and you should see the surrounding threats, the socio, areas of how the people are they well off, or are they the village people who are still the farmers but still will be able to pay and get a good job that is done. Then of course your environment where you select the your office setup is very important, surrounded by a calm and peaceful area, not in an area where always a lot of noise and talkings and discussions and arguments that take place. Better avoid that area. And then the ethical marketing is something which I have to stress here, because our profession is stooping down beyond a limit for their own benefit by, an unethical marketing is happening around, for which our council is also taking stern action. We have already put it in the website. So for whichever we get a complaint, we are taking actions against that. So please, I would like to convey this to our young professionals that we should have a dignity for ourselves and you should always understand and say that you are a dentist or you are a professional who is serving the community. So do not do the garment manufacturing or advertisement for your practice. I see some advertisements giving some reductions. It's so cheap. We have gone to that level. We don't have to. A person who has got confidence and skill need not stoop down. Only thing is, time is a matter. Instead of the first 2 years, he may take another 1 more year or 2 more years for the word of mouth, spread about your skills and your expertise about your clinic. So you need patience. That is what is long lasting. So that is what is going to help you. These advertisements, unethical marketing will help you for a very short time. Then the patient come and then they give a very bad remark about you or review about you, and there ends your career. So I always say, be prepared, skillful, and then start the practice and do it in an ethical manner so that you will last longer in your practice and very successful also. So coming to the investment consideration, this is another thing which I always would like to say, that many of us are well off now. I don't think anybody can say that I am poor, I don't have. And we have other backgrounds of supporting from the financial institutions also. But then I always say, whatever it is, you should know your limitation as an individual. Do not think that just because your father or somebody has got money, it's not that you have to just go and lavishly spend it. Your ambience is not going to talk. Your skill and knowledge and your soft skill especially is what going to talk, and how you carry yourself among the society is very, very important. Not the finance and the ambience what you create there. So you will be exposed in a very short time by your soft skill or by your performance. So never think that just because you have the social contact and you have financial background, you will be successful. That is where many people fail. So I would always say funding, you should never go beyond 30% of your ability. Forget about your other support from the background of the capital assets. Or if you are taking the finance also, you should be very careful in what you need initially. I would always say, do not compromise on the equipments or the infrastructure of performance of your skill, which may affect if you are compromising on that. Never do that. Always do get the best equipments or the better ones, not the very cheaper ones. And at least do that. From there on, you can always invest further, expand your clinic. So that's why I said, when you select an area, even if you're starting with a single chair, you should always keep space for another chair. And from that, you know that next chair will be your dream chair. So that is how, but doesn't mean that first chair should be a one which is not good or is not going to serve you or help you, because equipments and ergonomics are very important for our quality of work. So that is also very important. Then the operational cost also, you should know what are the salaries you'll have to pay, rent, utilities, and all other things. So salaries and our chairside assistants are something very, very important, which many people are not giving a due importance for that. That is what assesses your quality of work. How the soft skill, how they talk. Soft skill is something which I would like to again highlight here, because many of us, especially the younger generation, does not know how to talk. I'm not telling that you have to just talk by using all glorious words or and convince the patient. That's not soft skill. Soft skill is exactly to what the patient wanted to say. Allow them. First and foremost, you should have the ability to listen, and that is what is the very important skill you'll have to learn. Listening what the patient says. Before that, don't come to a conclusion. However experienced you are, hear what they say and then you reply. And by that, you will know what the psychology of the patient is and what is the socio-economic strata and the literacy level of the patient. Therefore, this should help you to understand what type of treatment, like not exactly the treatment or the cost of the work. Like, so some people will be ready to go for a zirconia crown rather than a metal crown. So you should also tell the patient according to their knowledge and the socioeconomic strata that these are all available, but you can, if they're not well-to-do from their way they talk and what their need is, you can go for a metal crown. It serves a function, but as far as the cosmetic is concerned, that may have to be compromised. So these are something which you'll have to always be open, and that is why I always say soft skill is very, very important in your practice. Patience on your side of hearing or listening to what the patient says is very important. Allow them to talk first. When they talk, when they speak itself, you will know what the diagnosis will be to a certain extent most of the time. So resource management is also very important. You should know what the patient's demand and what is the demand and supply there, and dental care as per the patient's age group. You should get into all levels of the communities, like geriatric or poor. It's not that only elite has to come to your clinic. You should have a separate timing or maybe a separate area to treat them the same way how you treat them, but may not be the luxury for what the elite wanted to be in an appointment time or an exclusive time for them. So you should always understand your surroundings of knowing what the community needs and therefore plan your practice. Now, next thing is your chairside assistants, your other resource persons, you should always see that you are having the good ones along with you, maybe a dental specialist or a hygienist or a chairside assistant, administrative staffs and receptionists. They're all very important. They play a key role in your clinical fortune or your success in the future. And you should have workforce management capacity. That is, you should have a continuous development program for your even chairside assistants or maybe your own attenders over there in your clinic. You should call for a meeting once in 2 months, or maybe little later, if you are developed well, you can have your manager or an experienced one to do that job. See that they are being empowered, they have been educated, and they should know what their task is. Never overlap the task between the workers, and that will cause confusion. That will not cause ego and problem. Ultimately, you have to suffer. It is not them. So these are some of the resource management and your ability. You should always understand where you stand, and accordingly you should plan. This is very important. Now coming to the financial planning, as I said before, see, you should have the 6 golden rules. Embrace goal-based approach, set a budget, use the 50-30-20 budgeting rule, incorporate no spending days also at times if needed, and find ways to increase your income and avoid lifestyles, inflated lifestyles. So now what is this 50-30-20? Apart from the tax deducted from the income. So when I say tax deducted from income for the beginners, I always say second or third month, if you are able to pay the rent back, be happy without asking others. Do not expect in the second month itself to pay back the loan and the rent as well as the salary for others. May not be possible. You should always have a working capital with you as a standby. You should not make your subordinates or the chairside assistants suffer because of your constraints financially, because they are more dependent on finance. So keep a extra budgetary allocation for them for the next 2 to 3 months, and then manage them, keep them happy. So this 50% of your taxed amount, that is the profit after tax, should be called or should be spent for needs. Needs, you can divide your lifestyle into needs, wants, and savings for the future. So needs is something which has to be there. That is, you will have to pay your basic groceries, your insurance, your household electricity. These are all must. So you cannot avoid that. That is what needs. So 50% of the money what you have saved beyond tax should be kept for that. And then 30% you can always use it for your wants. Wants are the ones which you can avoid. In case if you are, not getting so much for your luxury or for what you had during your college days by your parents' support, you should try to compromise on that. So you should always try to, consolidate that, take out dinners or movies or outings and so on and so forth. Then that remaining 20% should be always there in your mind to save. That habit should be there from the amount what you have saved after tax. So mind you again, my dear youngsters, do not think that you'll get a profit or a break even in the first 2 or 3 months. If you are able to pay the rent back with after the break even, that is a big success. So you need to be patient for such things. Then standard infection control, I don't have to say here, all of you know about it. I think last week, Dr. Gifty, I believe, he gave a wonderful lecture, and I think most of you would have heard about it, and you can learn about that in another session also. Now, biomedical waste, again, you all know how to segregate. These are all becoming mandatory now. Understand that India is not still backward, and our people not poor. We almost have crossed that limit. We are developing, or another 5 years, I think we should be developed also. So think and work in that manner that the patients, whoever comes to you, may not be highly educated or literate, but still they are able to pay to you. So at least use disposables and take and do the proper segregation of biomedical waste, which is very, very important as a responsibility to the society, as a professional. Please take this seriously. It's, of course, I know we also from the council as well as from the association of fighting are requesting the association reduce the amount, though it is little more, but they were giving their own practical problems. Maybe it takes time for us to ask them for a single chair clinic, how much can be reduced, but it is the same for even a medical practitioner also. So that is where we are also held up. There's a constant talk that is going with the DMS, Director of Medical Service. So that is, and coming to the safety consideration, This is how you should always keep in mind when you practice the informed consent. Nowadays, as an ethical chairman in the council, I see every month there are 3 to 4 complaints litigation coming up there with, for various reasons. What I understand that it's basically the communication, lack of communication. Second, I would have to openly say that it is a greed for money has caused this confusion with the or the rapport that is spoiled between the patient and the dentist. So I again humbly request our colleagues that do not be in haste to make money. Slowly you can make. Once you are confident in your work, you can raise your charges and you can lead your lifestyles what you are aiming for, but not at the cost of doing something unethically without proper communication and without proper patient education and without proper documentation. Now, documentation, informed consent, however we say there is a general consent, there is a procedural consent, these are all good. But when greed plays a role there and there, when there is a misunderstanding between the patient and the dentist, you will always end up in the litigations where you would have obviously done some mistake in some way or other, knowingly or unknowingly. And that is why we nowadays ask for an AV consent also, because patient says, I didn't understand the language, he told me to put the sign and we have done it. So there are so many ways where litigation can take over you and you will be in a problem. So audiovisual consent, again, how do you do it? You can do it with your cell phone, or you can always have a place in your clinical setup for the patient education area, which should have a camera and an audio recording. So whenever you feel that the backlog which you need for certain patients where you expect some problems, better record it and keep it safe. So that is where you are safer. So always be truthful, be honest to the patient, and be clear in what you're going to do and what is available and what your skills are. Do not give false impression to the patient that you are the best and the materials are the best and you are the God. Please understand, you are not the God. You are only doing what you have learned with your expert. Ultimately, anything can happen on a patient or a human body. Accept that and do it in a slow and polite and meaningful manner. And don't be harsh with the patients, and you and your subordinates should be dealt separately with the soft skill. Okay, then staff training, I told you, all of you should be equipped with this basic life support and an emergency equipment, which will be dealt in the next lecture, and emergency protocols, which will be also. Always give preference for the disabled also and for the poor also in your clinical setup, which will be a sense of social responsibility for the profession, what you have taken up. So that should be a part of your life in your long-term achieving the vision. So a good dentist not only keeps the patient safe, informed and educated, but keeps employees nourished and mentally alert, trained and updated. That is what is very, very important. So please keep your employees happy. Please have constant meeting. Have a free talk with them whenever you are free, and not to a very low level of talk. What I'm talking is, as a professional, as an entrepreneur, you should have your conversation in that limit. So this everybody should learn. Now, what is clinical establishment? There's a lot of hue and cry now. Please understand, my dear colleagues, we will have to follow this. Everybody asks, do we have to go for a fire safety? Do we have to go for a pollution control? Of course, we are competing globally now. Our people have developed, India is developing. We will have to have some safety protocol. So all these things are needed. I know initially it means a lot for a beginner, but then at a point where we have crossed now, we need to follow all those things. It is not cumbersome for a beginner. You can have a provisional registration and then you go for a permanent registration, because initially you will have problems, but then after a long time, after a bit of time, after provisional, I think they are giving around 6 months to get the final registration. And always the medical people are also receptive. For this, I think the associations can help, go in a group and request. They have already accepted for certain things like pollution control and AERB, as well as fire safety. They have made it a little easier. Of course, not biomedical waste. That is something very important. And your clinical records, this is something which has to be maintained to audit yourself and to assess yourself how your performances are. So these are some of the things which you should always follow, and do not grumble saying that Clinical Establishment Act is quite tough and bad and so on and so forth. Never think that. It's always for our development, our quality of work, as well as for our country's status. Now coming to the next one, let me go quickly. GST and trade is not basically for us, but if the clinic is selling some product, you have to be definitely under GST if it crosses beyond 20 lakhs. And if you are trading something else also along with your clinical product like brush, toothpaste and so on and so forth, medicines, then you need all this trade license. Also, you should actually speaking. So that is at the local municipal authorities. It is not strictly enforced, but then I think in the long run you may have to. GST need not be always, because I don't think you will cross over more than 20 lakhs, but still if you are doing something beyond your dental profession other than some trading, you have to. Now, consumer forum and public litigation, what constitutes a negligence? Negligence treatment, failure to provide agreed upon treatment on service. You say something and you do something. Even if the patient, if there is a failure in root canal, you can always say that there is a problem of failure because of certain things. Don't say that I will save the tooth, I will do the best. Say there is an infection there which I will try and I'll try to recover that, but their chances are 20 to 30% failures. Always give that ratio to them, put it in writing. Patient informed about the alternate treatment plan also. Always give an alternate treatment plan for what you have decided. So misleading or deceptive practices should not be there. A lack of proper hygiene, that is unsterile and aseptic, you know the things that's happening now. Failing to explain the procedure and potential risk. So avoid malpractices, claim and litigation. Attitude, auditing to the patient's feedback is very, very important. You will know where you stand, what your quality of work is. And then soft skill, as I told you, is very, very important, not only for you, for your subordinates in your clinic, that is the receptionist to the attenders. They should know how to behave or talk back to the patients because they are our ultimate assets. In case of litigation, take a proper legal representation. Of course, counsel is always there for the right, and as well as our association also to a certain extent, they can always back up. But most of the cases where I have seen, I told you openly because I am in that ethical committee, it is a greed for money as well as the soft skill or the lack of communication properly is the one which leads to many problems. So this is one of the examples. See, they have given a consumer negligence is they found that there appears to be a failure on the part of the doctor to inform the progress of the treatment. So communication failure. So they asked them to pay 2 lakhs in the consumer forum. So this is just an example I have put. Professional membership, as I told you, many people will ask, why should I be a member of Indian Dental Association or for that matter, specialty, what gives? See, please let us not ask that question. As Abdul Kalam said, do not ask what the government or India will do for you. What will you do for the professionals and the society is something you should always ask. Definitely, you may not like a leader or a government or a political party, but then ultimately it is a nation what has to develop and our profession which has to develop. So look into that. So always become a member, update. The main purpose of doing this is, one, they will give you ethical safety and support. Second, you will develop in the various programs what they are conducting, like continuing dental education, various symposiums and various trade and other things are happening. So please do not hesitate and don't ask questions why, what benefit. I think they are doing whatever possible and it's slowly developing. It will develop, it is emerging, it is evolving, associations also. So please understand this, you should be the member of all these associations, and of course council registration is mandatory, and they have given the 19 for the jurisprudence is something. This is an association what we give. So continuous professional development, my dear colleagues, is very, very important now. Every week the techniques changes, the material evolves and you are reaching higher and higher. If you are not updating yourself, you will be lost. For sure, take it in writing. You will be lost if you are not updated, because the patient now, the Google is there, they can search, patient come with little knowledge, or at least the nearby, their friend will say something. So they come with certain knowledge. It's not that they are dumb like before and they will believe you as a God. You know, there were times where we were worshipped like gods. Now the scenario is the other way if we put the word of God. So that is because of our behavior among the colleague or the public. So continuous professional development, I insist all the youngsters to please take it seriously and update, upskill your knowledge. Learning is not the end after your college. You will always learn, unlearn and relearn. That mental ability and attitude should be there. This attitudinal challenge is always there. Even I tell you, after 30 years, I still wanted to learn and I'm ready to say, I don't know. I'm ready to refer to somebody who is better off than me, or I can refer the patient to them. So that mental attitude or ability or acceptance should be there among our colleagues. So your failure rates will be very less as long as you're open to your colleague or patients, and as well as among your fraternal colleagues, you will be successful. So the benefits of this I have mentioned here: personal advancement, patient care, regulatory requirements, professional growth, and shared resources by like what we have today, the webinars and other trainings. So dental jurisprudence is something, again, everybody should know what a 1948 Act is, Dentist Act. Everybody knows there is an act in the council, but we have done a study, somebody has done a study and it says only 60% knows that there is an act, out of which only 30% knows whether we can sell a medicine, that is our dental related product in our clinic, which you don't need to get a license. But you have to sell only that, not beyond that. So these are all small things. When you go into the jurisprudence, you will learn. So you should know what the legal framework is, what an ethical consideration is, what is the professional standard you should follow according to the people, what they expect in the area, what you, where you practice. So these are some of the things which is very important. And now knowledge of dental jurisprudence, this is what I told you, the article which says 65% of the dentist knows about it. But only 30% or 33% knows that the dentist can sell dental medicine, that is painkiller and antibiotics and toothpaste in his clinic and toothbrushes. That doesn't need a pharmacy license for that. The dentist has to do that. So not the other things, beyond that you cannot sell. Then you need a GST for that, of course. And and remaining people responded that they don't know that such things are existing. So that's what this article is about. And this is again the takeover message. In short, I would like to conclude here is the Dental Council Act, everybody should go through. Then you will know what is a code of conduct. Code of conduct, recently also we had problems. We are inquiring that wherever necessary, council goes suo moto actions also are being taken, or the association represents. But then we find that there is a lacune there. The individual who has been affected is not in the proper documentation. So we are sometimes not in a position to help them. So please follow all the documentation procedures, whichever I have said before, and the duties and obligation of the dentist in general, character of a dentist and a dental surgeon is very important. And never treat a patient alone in your clinic. Always have a standby attender, maybe of an opposite gender, preferably, or an audio-visual camera should be there, or a visual camera should be there. But again, that also has to be said in the reception that you are watched by the camera. Otherwise, again, it is illegal if you are not expressing the talk because of certain other reasons. So please put that also, that you are being monitored. So therefore, this is my book. If others wanted, or the young dentists written, it is available in Amazon. You can just get it. So therefore, a dentist or a dental professional should be an entrepreneur. And I feel that you have got some idea about it, and you will cling on to this, and you will follow and be a successful dentist. That is what I wanted. With a dignity, your profession should grow. And with this, let me end here. And I thank Dr. Manika Vasagam for this opportunity in a crisp manner I have given. Now let me hand over the platform to Dr. Reena, where she'll be talking about the medical emergencies in the clinical setup, which is very, very important, of the challenges what you face. Thank you so much. Your questions will be taken at the last together. Thank you.
Thank you so much, sir. That was a really wonderful session, sir. And all the participants, if you have any doubts, you can clarify after the second session. And over to you, Dr. Reena, ma'am. You can take over now. Thank you.
Thank you, sir.
Yeah, very good evening to all here, and I thank. Can you hear me, Dr. Manika Vasikam? Yeah.
Yes, ma'am. Yes, ma'am.
Yeah, a very good evening, and thank you, Dr. Manika Vasagam, and the team Dental Vriksha for giving me this opportunity through Dr. Babyjohn to speak on the management of medical emergencies in a clinical setup. This is very important because I think medical emergencies are something that can be avoided and mostly prevented. That is something that we need to identify in its earliest point. So if when a person, it may be a patient, it may be an attender, it may be one of your team members even, when they come across an acute illness which may pose an immediate risk to the person's life, then that is a medical emergency. And that could be because of some precipitating factors in our clinic, or maybe because of some deteriorating or pre-existing comorbidity. This can happen to anyone. It can happen to the patient, to the attender, to your staff, your nurse. You yourself can have a medical emergency while you are managing a patient. It can happen anywhere. It can be in your treatment room. It can be outside the clinic in the waiting room. Maybe even after you have discharged your patient from your clinic and when the patient has gone back home. Yes, and the precipitating factors for medical emergencies are obviously stress. Any patient coming into the dental clinic, we think our dental clinic is very comfortable because we are there every day. But a patient who comes to the dental clinic may be coming with many worries of their own, may have pain, may be stressed, and the sight of our clinic itself and the sight of us and the the injection can cause a lot of stress. Maybe the patient is on some drugs, on some medications for some ailment of theirs, or it may be age related. Long waiting periods in our waiting area, long appointments can also be precipitating factors for medical emergency. So important thing is how you evaluate the patient and how you stratify the risk. So medical emergencies, as I said earlier, is preventable. And the most important thing is creating, you're creating a communication with the patient. As the patient walks into your clinic itself, you have to give the ambience of a very comfortable ambience, and you should take a history in such a way that you want to know the patient, not just know what the dental problem is, but know what the patient has come for, what the psychological, everyone does not have the same psychological tolerance level. So the psychological evaluation as you're talking to the patient and trying to understand what the problem is for which the patient is visiting your clinic. The visual inspection, take time to actually talk to the patient and to examine the patient, because then you will be able to stratify the risk that the patient has to develop a medical emergency. And if and when needed, a medical consultation and speaking to their physician is very important, and stress reduction protocol. And as per that, you would stratify the patient as an ASA 1 to ASA 5. Obviously, it will be an ASA 1 or 2 that the patient will visit to your clinic. Sometimes even ASA 3, where they have systemic conditions which are quite serious but not incapacitating, and those are the people who will be prone for a medical emergency. But even an ASA 2 and 1 can develop a medical emergency in our dental clinic. So the stress reduction protocol is pre-medicate. When you see that the patient is a little anxious, give them a midazolam, an alprazolam, 0.25 milligrams, half an hour before your procedure. Appointment schedule can be made earlier in the day and minimize the waiting time. Intraoperatively also, you could give good anesthesia, good pain control, and talk to, many times vocal anesthesia is even better than oral anesthesia, and short duration of treatment. Just because we have to make money for that particular, we have a target to make, we should not extend the treatments that you can do for the patient to make the money. That shouldn't be our objective. And of course, the post-operative control of pain and anxiety. How do you, prepare and prevent medical emergency? When you prepare for an emergency, the emergency ceases to exist. So the most important in preparation of your medical emergency is, remember, you are not alone. In your clinic, you have a team. You are there, your chairside assistant is there, your receptionist is there. You all are a team. That is important. Managing the team is important, and emergency practice drills are very important. And you should have a training on BLS. So the team, you should assign duties for each team member. It may be a chairside assistant, your receptionist. But when there is a medical emergency, you should tell them, team member 1, it may be your chairside assistant, tell them that or it may be your dental, assistant doctor, tell her or him that you should provide the BLS, and as indicated in the BLS training. And you should stay with the victim when there is an emergency and alert the office staff members. The team member 2 should have duties such as bring the emergency drug kit, bring the oxygen cylinder, bring the AED to the where the patient has collapsed. Check the oxygen daily in the oxygen cylinder, check the emergency kit weekly, and check AED. These should be protocols that are assigned to one particular team member of your clinic. And team member 3 will be the one who will assist you when you're doing your BLS, monitoring the vital sign, the pulse, the the respiration, making documentation, recording the time when it occurred, and what has been done first, what has been done second, all those records being maintained, and preparing the emergency. You need to load all those emergency drugs in your in the syringe. All that is done by the team member 3. So each team member should know what he or she should be doing. There should not be a confusion, and as you're doing this, you would have called for the emergency management system, to the nearby hospital. And when those people come to your office, the team member 3 should be ready to receive them and bring them to the site of emergency. So obviously, prevention of medical emergency basically is about a holistic patient evaluation. That is, when the patient walks in, you're evaluating as you're speaking to the patient and examining the patient, and then coming to a tailored treatment plan, breaking it out into small appointments, and then giving effective management of patient pain and anxiety. This will help you prevent medical emergency. That is most important than managing medical emergency. So when we are talking about emergency medical services call, it is calling to the nearby hospital, or because you should have a list of hospitals that are nearby who will respond to your emergency call, and then telling them where your clinic is, what is the name of your street, road, everything, your telephone number, the nature of emergency, how many persons need help, what is the condition of the victim, are you giving CPR or have you started using AED? All these information should be given when you're giving an EMS call. So the team member who is giving the emergency medical service call should know that these are the information that you should be giving. And as a principle, the first thing that you should do in an emergency is assess the patient and start off with the BLS. Try not to give any medication if you're not sure. And in your clinic, you should definitely have these drugs. Glyceryl trinitrate is a vasodilator, which is essential in angina, right? Salbutamol is a bronchodilator if there is an asthmatic attack. Adrenaline injection, obviously you need it if there is an anaphylaxis. Thankfully, we don't see anaphylaxis so commonly. Aspirin, if there is an angina which is not being relieved by glyceryl trinitrate, you would give aspirin. Glucagon injection, if you don't have, the patient's unconscious and you don't have dextrose to be given IV, then you can give IM glucagon 1 milligram injection. Oral glucose, if the patient is conscious and is going into hypoglycemia, you will give oral glucose. Midazolam, if the patient is going into a seizure. And of course, you should have an oxygen cylinder. This is very critical and essential that you have in your clinic. Flumazenil, if you are doing conscious sedation, then flumazenil is an antidote to benzodiazepine, and you should have that if you practice conscious sedation. So the important thing is you should keep it simple. Keep it simple. Each member should know what they should do. You should know what emergency drugs you should have, and you should know where it is kept and who is going to handle it. Keep it simple. Other things that you should have is your portable oxygen cylinder, the D size, the face, this oxygen mask and tubing. This nasal prongs can be kept in yours. You could have these oropharyngeal airways that you can see on it just costs 200-300 rupees. You could even have an ambu bag, right? You should have a suction catheter. You could have a spacer divisor. You could have an AED also. That will be good. And of course, sterile syringes and needles. So management of medical emergencies will not, it should start from the point of occurrence, and you should have two competent, your clinic should not be crowded. When you're managing a patient, there should be two competent adults who are managing. It should be a continuous patient assessment during the treatment, and your emergency contacts and services you should have access to, and you should have periodic staff training. And assessment of when there's a medical emergency, what is it that you are assessing? What is the sequence of assessing? It is A, B, C, D, E. That's airway, breathing, circulation, disability, and exposure, right? And how would you want to give the drug that you want to give? The fastest is the endotracheal and the slowest is the intramuscular. You can give it endotracheal, intravenous, intranasal, sublingual, or intramuscular. So when you're giving an injection, these are the directions. So intramuscular, your injections will go perpendicular to the muscle. If you're giving subcutaneous, it is at 45-degree angle. Intravenous, it is at 25-degree angle. Intradermal, you can see that it's at 10 to 50, less than 10 degrees angle, right? And the hand grip you can see on the lower left side. So when you're giving an intramuscular, it's going through skin, subcutaneous tissue, and into the muscle, into the substance of the muscle. So these are some of the areas where you can give intramuscular, the lateral part of the thigh, easiest area where you can give an intramuscular injection, that's the vastus lateralis injection, or the deltoid injection from the acromion process around 10 centimeters below the acromion process, right in the center of the deltoid muscle. You can avoid the brachial plexus. There you can give the intramuscular. Or you can give the ventrogluteal in the lateral part of the thigh. You can give the, not the thigh, the hip. You can give the ventrogluteal injection. Or you can give an intralingual injection through the mouth or extraoral. All these are easy ways of administering the drug and safe ways of administering the drug. Now, how do you assess whether the patient is sick? You see the patient, you see the eyes are dilated, the limbs are flaccid, there's no control over the limbs. The patient is, not responding to you. You're asking the patient, how are you? Are you okay? And the patient is not responsive, then you know that the patient is not well. And if the patient is not breathing and if the patient does not have a pulse, then definitely you have to start your CPR. So airway, what we said is you should assess the airway. If you look at this picture on the left side of your screen, you see when the patient is lying on your dental chair, the chin is falling back. And when the chin is falling back, the tongue is falling back. You see that the air that is entering through the nose is going back through the nose. It is not going down to the trachea, right? So what you need to do is a head tilt, put your hand over the forehead, tilt the head and lift the chin up. When you do that, you open up the airway. Can you see that on the right side? The airway is opened up, and that simple maneuver will cause air to enter into the lungs. And some of the adjuncts that you can use is the nasopharyngeal airway that you can see there. Very easy to use it actually. An oropharyngeal airway, the steps in which it has to be used, that just brings the tongue forward and opens up the airway. The second thing is breathing. As you're assessing this, you're looking at the chest movements, listening to the air that is coming out through the nose and the mouth, and you're feeling the air against your cheek. And therefore, you know whether the patient is breathing or not, right? And circulation is, look at the color of the hands and fingers. Is it blue? Is it pink? Is it pale? You press the fingernails, and the capillary refill should happen within 2 seconds. Is the patient's hands cool or warm? If it is cold, that means there is no, the circulation is not good. Check the pulse rate. That is very important. Disability is the easy way, there's a Glasgow coma scale, but the easiest way of understanding whether the patient is alert or not, or awake or not, or conscious or not, is the AVPU. That is alert, or is the patient responding to vocal stimuli, or is the patient only responding to painful stimuli, or is the patient unresponsive to all stimuli. And exposure, you need to expose and see if there is any other, rashes. Is it an anaphylaxis? And you need to open up the clothes and at the same time maintain the patient's dignity. And when you're doing that, if you're a male doctor, you should have a female assistant there, so that there is no compromising situation. And that is how the steps of bringing the patient to recovery position, putting the hand in that position, and then taking the other hand over the neck and turning the patient over so that the patient is in a lateral position. That is the recovery position that you see, right? So the principles of medical emergency management are recognize the problem, discontinue the treatment. Negligence is when you have not recognized the problem and you lose the patient on the dental chair. That is a non-bailable offense. So recognize the problem, discontinue the treatment, activate the emergency system, prevent injury to the patient, and monitor vital signs. And the algorithm is position the patient, check the airway, as I said earlier, breathing and circulation. Some of the most common is the vasovagal syncope. That is the most common, just fainting. Yeah. So in that, the only thing you need to do is position the patient properly so that the brain and the heart is in the same level, anxiety relief, and then think of postponing the treatment to a later time. So position the patient with feet slightly elevated so that the venous return is better. The ABC, that is the airway, breathing, circulation, the putting the head tilt, chin thrust, chin lift position. Administer oxygen 5 to 6 liters per minute. Monitor the vital signs. You have a pulse oximeter, you can put it on, you can see the pulse rate and the oxygen saturation. You can use aromatic ammonia vaporol to bring them back. And this is the supine position in the dental chair that is the same. So sometimes as you're doing some procedure or even extracting a tooth, you can, it can slip into the throat, and if it goes into the airway, then there's a problem. The best way to avoid it is using a rubber dam, packing the oral cavity, the chair position, having a dental assistant, and having good suction. But if something like that happens, you can use this Meggle's forceps to retrieve the dislodged, material. And this is the lateral decubitus position that you can put so that the patient is, not the, once the object has come out, you can put for recovery position. And that's the Meggle forceps in use, and the tongue grasping to bring it forward to see if there is any object inside. So if there's a complete airway obstruction, you will not hear any voice of the breathing. What you can do, and the patient will not be, this is a typical sign of complete airway obstruction. Inability to speak, inability to breathe, inability to cough. This is the universal sign of choking. There's a panic, and you need to identify what could have caused that obstruction. And abdominal thrust is the best way to expel the the obstructed material and bring the patient back. So if the patient has lost consciousness, supine position, call for help, the usual thing that I said earlier, and abdominal thrust. So how do you do abdominal thrust? One is back blow. The other is the Heimlich's maneuver, where you stand behind the patient, hold the patient below the diaphragm and give upward thrust. Or on the dental chair, that is the way you do an abdominal thrust. For a pregnant lady, it will be just below the or above the gravid uterus. You keep your fists and you push upwards. That's the abdominal thrust on the floor. So position the patient in children, in infants. You could do 5 back slaps and 5 chest, like this. If there is an obstruction, 5 back slaps and 5 chest thrusts in an infant till the patient becomes responsive. If there is an asthma, do not put the patient in a supine position. Put a patient in the upright position. ABC, airway, breathing, circulation, as I said earlier. And then administer asthalin or salbutamol via inhalation. Administer oxygen. If the patient is still unresponsive, the last thing you could do is epinephrine 1:1000, 0.3 to 0.5 ml subcutaneous. You remember the subcutaneous, what I said, how in what angle you would give, around 30 to 45 degree angle you would give it into the skin, right? And repeat it every 20 minutes. This is a spacer. This allows the medication to stay in that area, and the delivery of the drug is better. Hyperventilation, another. So vasovagal syncope is one which is very common. The second common thing is hyperventilation. How do you know the difference between the two? In hyperventilation, what happens? The patient may lose consciousness, but will have a carpopedal spasm because of hypocalcemia. Here, you do not give oxygen. This is the only condition where you do not give oxygen. What you need to do is ask the patient to breathe into their cupped hands, so that breathing, here there's a washout of carbon dioxide. So breathing in the carbon dioxide that has been exhaled and calming the patient is important. If the spasm of the fingers and the legs are very bad, then you can give calcium gluconate injection. Hypoglycemia is another very common medical emergency. Here you discontinue the treatment. You know from the history that the patient is diabetic, and the patient may have missed a meal because of the dental appointment. Obviously, you have to do, if the patient is conscious, you will give glucose in the mouth, and it gets absorbed from the sublingual area, and there should be an improvement. If there is no improvement, you should immediately call the emergency medical service. But if the patient is unconscious, then in addition to all this, you have to give IV 50% dextrose or 1 milligram glucagon, as I said earlier, IV or IM, or transmucosal or rectal honey or syrup can be given. But I think the best thing to do is either give 1 milligram glucagon IV or IM, and or 50% dextrose IV can be given. So if neither glucagon nor dextrose is available, you can give 0.5 milligram of 1:1000 epinephrine. But the best thing to do is give glucagon or 50% dextrose. Stroke can happen on your chair, and the best way to see it is, sometimes suddenly the face starts drooping on one side. The arms, if you ask the patient to touch the nose, the patient is not able, the speech becomes slurred, and time is a huge factor here. You need to identify it as early as possible. So here, positioning the patient, BLS as needed, and activate EMS, administer oxygen. Immediately call for the ambulance so that the patient is shifted to the hospital. Seizures is another thing that can happen in your dental chair. And in seizures, usually seizures will stop within a few seconds, at the most a minute. So you just see that all the instruments are moved away so that the patient is not harmed, and the seizure completes, and then you can give oxygen, and it should be all right. But if there is a status epilepticus, what do? You have, because then what will happen is there's going to be a respiratory embarrassment, because status epilepticus is when it has gone over 3 to 5 minutes. That is huge. Then if you have not acted, you may lose the patient. You need to give diazepam 5 to 20 milligrams IV, or intranasal lorazepam 2 to 4 milligrams, or intranasal midazolam 5 milligrams. That is only in case of status epilepticus. Anaphylaxis never happens. Pray that it never happens in your dental clinic, because it's so difficult to manage and get back the patient. But again, it is airway, breathing, circulation. Call the EMS. Epinephrine is the first drug of choice in anaphylaxis, and then giving oxygen, and you can give antihistamines and corticosteroid. So when you're giving anaphylaxis, epinephrine in anaphylaxis, it's 0.3 milligrams in adults, 0.15 milligrams in children, and in infants it's 0.075 milligrams, and you can give it 5 to 20 minutes, every 5 to 20 minutes as needed. You can give it IV slowly over 3 to 5 minutes. This is a typical, if you have a chest pain, that's a typical Levine sign that you see. And if you have a patient having a chest pain, holding on to the chest, the first drug that you would give, apart from positioning the patient comfortably and airway, breathing, circulation, nitroglycerine 0.3 to 0.6 milligram spray, or putting sublingual tablet, and giving oxygen is the best. And then you can give aspirin if pain is not relieved. Call for emergency medical service and shift the patient to the hospital. Acute myocardial infarction, again, positioning the patient, ABC, and emergency medical service. And myocardial infarction, the pain will be so bad, it is not being, relieved by nitroglycerine or by aspirin. Then you need to give morphine, parenteral morphine, 10 milligrams, or nitrous oxide. Maybe we are not equipped to do that, but emergency medical service, and at least that this has to be done, can be, communicated to the hospital, so they bring it there and can be given in your clinic itself. Nitrous oxide, oxygen also. Acute adrenal insufficiency, again, history if you have taken and the patient has been on corticosteroid for a prolonged period of time, you would have to double the dose when you're doing a dental treatment. But if you have not done that and the patient is suddenly collapsing, your first diagnosis will be, oh my God, this could be an acute adrenal insufficiency. So what you need to do is, again, position the patient, ABC, administer oxygen, and hydrocortisone, efcorlin, 100 milligrams, or dexamethasone, 4 milligrams should be given IV. Cardiac arrest. Now, cardiac arrest is different from myocardial infarction and angina. There it is pain. The patient is responding, telling you there's pain, severe pain. But cardiac arrest is when the patient is not responsive, not breathing, no pulse, then definitely you have to start your CPR. So what is the need for CPR is that when you do CPR, when you're pushing the chest down, what happens is when the patient is arresting, there's some amount of oxygenated blood in the arterial system. And when you're compressing it, what is happening is there's an increase in the intrathoracic pressure, which increases the cardiac output. The blood vessels start opening out, and the blood starts flowing to the other organs. And then when it is released, there's a venous return. Along with the venous return, when there's a recoil of the chest compression, there is also air entering into the system. That is why the cardiac compressions have to be effective. And this is a normal sinus rhythm. If you see a ECG, this is normal. While this is abnormal, this is ventricular fibrillation, and this usually happens in cardiac arrest. Okay, and before you do defibrillation, if you've done your CPR, that is very good, because you have good oxygenated blood, and the chances of the shock delivered by AED being successful is higher. Okay, so CPR is important, and CPR should be followed by AED, and it just doubles and quadruples the survival from out of hospital cardiac arrest. So that's an AED that you see there, and defibrillation within 3 to 5 minutes of collapse can provide a survival rate of 50 to 70%. As I said earlier, in CPR, the cardiac compression is most important, more important than an artificial respiration, especially if you have untrained people and you're unable to do the rescue breaths. So when there is, till now we were saying ABC, 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 but when there is a cardiac arrest, it is chest compression first, then airway, breathing, and defibrillation. So early recognition, early CPR, early defibrillation, and early advanced care gives you better survival. So in earlier emergencies, I said airway, breathing, circulation. But cardiac arrest, it is circulation, airway, breathing. So ensure that the victim is safe, check for responsiveness, that is check the pulse, check the breathing, and then shout for help. And then if you have a mobile, keep it on speaker mode so that you can, talk to the hospital that you're talking to. And then if you're alone, bring the AED. If you have the AED in the clinic, bring it to the place where you are, where the patient is collapsed. If somebody else is there, ask that person to bring it. See if the tongue has fallen back, bring it forward. Yeah, check the airway, breathing, circulation, the pulse. The upper border of the thyroid cartilage, anterior border of the sternoid muscle. Just slip it down and feel for the carotid pulse, right? And sometimes you may have just gasping. That is very, 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 very suspicious of very bad situation. And chest compression at the, center of the chest. The elbow should be straight. The fingers should be interlocked, and there should be no contact between fingers and chest. Fingers should be up like that. And that's the way you should not bend your elbow. Elbow should be straight, and the compression should be given very well. That's just a video of a compression where a person is, collapsing. The person comes running, shouts for help, yes, and look at the way that compression is being done, right? At the zippy sternum, look at the way the fingers are clasped. The fingers are not touching the chest. It is the wrist, that area. Yeah, and that's the beat, that song is staying alive. That is the beat at which it should be given, right? So compress at the rate of 100 to 120 beats compressions per minute. Compress at least to 2 inches, and then allow the chest to recoil so that the air is taken into the thoracic cavity, and minimize the interruptions in compression. So push hard, push fast, full recoil, and minimize interruptions. That's very important. And you can perform. Ideally, you would like to do a chest compression on the floor, but you can perform it on the dental chair also. So open up the airway, get a good seal of the mouth to the, mouth to mouth, and then blow. The blow should not be short gasps. It should not be fast, but it should be continuous and slow. Mouth-to-mouth ventilation, and sometimes the patient may have a tracheostomy tube in your clinic. Sometimes patients who have undergone other treatments may walk in, so then you may have to do it into the tracheostomy tube. But if the patient has had a hydrogen cyanide or sulfide poisoning, then you don't do mouth-to-mouth resuscitation. You use barrier devices like this, and you give a resuscitation. You can use a bag valve mask where you can, hold it with an EC clasp. That's an E that you can see, and an EC clasp, okay? And deliver each breath over 1 second. The breathing rate is 10 to 12 per minute. And you see the rise of your chest with each breath that you give. And resume chest compressions in less than 10 seconds. So the ratio of CPR is 30 chest compressions to 2 breaths, okay? And that is when you have one rescuer. When you have 2 rescuers, it's 15:2. Right? And switch switch between your compressors within, it should be fast. Within 5 seconds, you should be able to switch. And that's the AED that I showed you earlier. Pulseless ventricular tachycardia is shockable. Ventricular fibrillation is shockable. But if you have a pulseless just an electrical activity, it is not shockable. You've lost the patient. Asystole, you cannot use an AED, right? And that's where you place the pads of the AED, right? Either sternoapical or anterior posterior. This is for us to know. Even if somebody else is doing, whether the person is doing it right or wrong. That's all, right? And you should not touch the patient when the defibrillation is occurring, okay? And you continue CPR till somebody tells you to stop, or till you become exhausted, or when the patient has recovered. CPR for children is similar to the adults. You give the same thing, only thing the amount of pressure. For infants, you use 2-finger pressure. For children, it is just like the adults. For infants, you can check the brachial pulse, while for adults, you are checking the carotid pulse. Okay, this is how you give a compression for an infant. In pregnant individuals, in pregnant women, you give a lateral lift. You put some cushions under so that you lift the board, and then you give the pressure so that the inferior vena cava compression does not happen by the gravid uterus. Okay, so that's about that. So the pearls are what now? If it is one rescuer, it is 30:2. If it is what is 30? 30 is the compression, 2 is the breaths. If it's 2 rescuers, then it's 15 compressions to 2 breaths. Okay, and the rate of external compression is, whether it's an adult, child or infant, it is more than 100 per minute. In infants, it is with 2 finger pressure. Okay, and the location is, in adult and child, it is the center of the chest between the nipples, lower half, the xiphisternum, while in infants, it's 1 finger width below the nipple line. Okay, the depth is, in adult and child, it is 2 inches, that is 5 centimeters, while in infants, it is 1.5 inches, 4 centimeters. Right? The rate is, in adults, of the respiration, the breathing, in adults 10 to 12 per minute, while in child it is 20 per minute. So, and as you're doing this BLS, you assess the pulse. First thing is, within 10 seconds, you assess the pulse and deliver the breath in 1 second. But the next pulse check should be done every 2 minutes, and delivery of shock. AED is brought in, and within less than 3 minutes, you give the AED. Pre and post shock pause is less than 10 seconds. And switching between the rescuers when you're tired, it should be less than 5 seconds. Chest compression fraction should be, that means the amount of chest compression that you're doing should be more than 60%. Only then your CPR will be effective. So in summary, recognize cardiac arrest. How do you recognize cardiac arrest? No pulse, no response, no breath, cardiac arrest. Activate the emergency call. The team member 3 should have called the EMS to ask for the ambulance to come and respond quickly and confidently. Most importantly, stay calm. This is all that I had to say. I hope I have kept my time, and I hope I was clear on what you should do, when, how to recognize, and what is a drug, and what is it that you should do when you have a medical emergency.
Very informative, madam. Even it's not for only beginners, it is for everyone who has a dental clinic. Even after 32 years of experience, I have taken few notes. I think this presentation is very, very useful for everyone. Now I am opening the forum for the participants to ask their doubts. Either they can unmute yourselves and then ask your question, or you can put your question in the chat box, whichever is easy for you.
Thank you. Thank you so much. Thank you, Dr. Manikavasan.
Hello, sir, Dr. Babyjohn, Mrs. Babyjohn, you both are rocking. Now only I came to know. Good evening. You both are rocking. The first time I'm hearing your both lectures you made for each other. Wonderful lecture. Same wavelength, perfect lecture. And I'm fan of Dr. Babyjohn lecture. He's the best stage doc in IDA.
Thank you.
Thank you. Thank you.
Thank you, Dr.
It's very useful, well arranged words, each one. ரொம்ப யூஸ்ஃபுல்லா இருந்தது, கண்டினியூட்டியா இருந்தது. ஒரு செகண்ட் கூட நீங்க கேப் விடாம பேசுனது வந்து ரியலி அமேசிங். ஐ வாஸ் என்ஜாயிங் போத் லெக்சர்ஸ்.
Thank you, Dr. Nanda. Thank you.
Okay, அதனால no doubt you have completed everything. அதனால that's why I have no doubt.
There's a question, I think. Kindly, sir.
Okay.
Thank you, madam.
Kindly tell the location of the CPR again. What is that? Oh, location of the CPR.
Yeah. So what I said was, you have your sternum, right? Your manubrium sternum and the midline, right? And you have the xiphisternum. That's just above the diaphragm. So center of the chest in Chonapodon, that is where you will sing. While in infants, it is between the nipple line, just below the nipple line. That is where the infants is, where you put 2 fingers and then compress there. For adults, it is near the xiphisternum, center of the chest, above the diaphragm. There's another question, I think. Did you understand that, Dr. S, it is written? Did you understand that? S, I don't know the name. Kindly tell the location of the CPR again, madam. Did you understand that?
That's the question we answered. Yes, ma'am.
Yeah, they understand. Okay. Ma'am, sometimes patients report back after 1 day with angioedema, how to treat them. Yeah. So angioedema you're talking about is swelling around the lip, right? Yeah. So you can, thank you. So you can give an antihistaminic, you can give a steroid. you can. Along with that, you can give an anti-inflammatory. So an angioedema is usually an allergic reaction. It should respond to antihistaminic and steroid. Dexamethasone 4 milligrams is good enough. Ma'am, if someone lost consciousness, 1 minute, let me read that. If someone lost consciousness in the dental chair, how can we find whether it is due to hypoglycemia or syncope? Fantastic question. Because the most common emergencies in the dental clinic are these two: syncope, hypoglycemia, right? So that is where our history is very important, right? If we have spoken to our patient, we know that the patient is diabetic, definitely the chances are, and if the patient has, you've given somewhere in the afternoon, sometimes in the morning also, may not have had breakfast, that it could be because of hypoglycemia. But if the first thing is positioning, whether it's hypoglycemia or syncope, the first thing is positioning the patient, no? Positioning the patient and, trying to get, are you all right? You want to sprinkle some water and you can give aromatic ammonia. Now, if it is syncope, the patient would have come back because you're putting the patient in a supine position, the brain and the heart are in the same level. And vasovagal syncope is a transient cerebral ischemia where when your circulatory system is the same level, the blood to the brain also becomes restored, and it is a self-correcting situation. But hypoglycemia will not get corrected even with that positioning. That is when you know that, okay, diabetic, okay, the patient has been with me for some time. Maybe the patient did not have, so most probably it could be hypoglycemia. You could just put some, put some glucose. You will have glucose powder, no? You could put that under the tongue, and you will find that the patient is, responding or recovering. But if the patient has lost consciousness, then you have to either glucagon or dextrose, you will have to give IV. IV at that time, many of us, it's very easy for us to sit and talk. When it actually happens in our clinic, we will panic. So better than IV would be if you have glucagon 1 milligram and you just give IM, and I showed you which sites you can give IM. You give IM injection, I think that would be the fastest way of getting the patient back. Yeah. Somebody is asking me whether we can give adrenaline and anaphylactic shock. Yes, that is the first drug of choice. Anaphylactic shock, the first drug of choice is adrenaline. Yes. We should pray. Actually, anaphylactic shock is very, very rare. Medical people get very paranoid about anaphylactic shock. That is why even for lignocaine, they will do a test dose and only give lignocaine. But we give it left, right, and center very confidently. But still, we have to be sure. If it is an anaphylactic shock, we have to give adrenaline. We should have adrenaline in our emergency drug thing. Yeah, it is not. Yeah, it is not commonly available. Last time, I think IDA gave us a pack of our emergency kit where adrenaline was available. Sometimes only from hospitals you can get, and you should also see the expiry date of the drug. Yeah. How do we find difference between syncope and stroke? Is very easy, madam. Same person is asked. Stroke, the face, the angle of the mouth goes towards one side. Patient or a speech one day, it'll be slurred. Upway, you should understand, this patient is, I think, developing a stroke. It's a gradual thing. We should identify it early. We can't do much. We have to give oxygen and then give aspirin maybe, and then call for the ambulance to sing. Oxygen cylinder necessary in the clinical setup or ambu bag alone? No, oxygen cylinder is absolutely essential in the and it is not expensive also. The first time I think we pay 5,000. After that, for the cylinders to be, it's only refill of the cylinder. It's only 500 or 750 rupees. So I think you should have oxygen, and you should have somebody to check it every day. That's another thing, because there can be leaks. No, and when you have a cylinder but it's empty, when an emergency happens, then that is also neglect.
Is a supporting thing for the medical negligence.
Ma'am, one doubt, ma'am.
Yeah, please go ahead, sir.
Ma'am, how long we can keep the emergency drugs in a dental clinic, ma'am?
You should keep you should keep your looking at the expiry date. And, that's why weekly once one of your team members should be responsible for checking the emergency kit, all the medicines, the list you should have a list there, and then you should see when the expiry date is and see that it's replaced. You should always have all those emergency drugs that I told you. Common emergency drugs.
Definitely this will go without use for sure, but then still as a part of medical negligence, this is something which you should have it in your clinic where pasted, at least in case of any emergency such things happens, at least you can have the evidence of showing that you have used it, you have had this and all those things. And always you'll have to have a discipline of checking it every month for the expiry date, because this quite commonly happens and you'll have to replenish this. Again, you'll have to get it back.
And it's not too
It's
much
not
of an
expensive. It is
expense.
very, very cheap. But these cheap things are very, very important to safeguard you in the Medical Negligence Act for problems.
And also you become a responsible dental professional, no? So you care for your patient. That's why you're doing that, right?
Thank you, ma'am.
Thank you. That's all. Any other questions, Dr. Manika Vasikam?
Yes, madam. Even I have a question. It is not making you commit for something. I'm just asking you, like a fellow practitioner, ma'am. Most of the heart patients, when we send for the doctor's opinion, they say avoid adrenaline, use only plain lignocaine. But the dentists always say the only adrenaline combination is the best and safe, as it produces the arteries, vasoconstriction and all that. So which one to follow, ma'am? Whether the cardiologist or the experience?
Very important question, Dr. Manika Vasagam, because as I told earlier, our medical colleagues, they are paranoid about lignocaine, and they are paranoid about lignocaine with adrenaline. Now, the advantage of using lignocaine with adrenaline in the oral cavity for us is that it gives you vasoconstriction, so better visibility, the bleeding is less, so we want to use that. But what they think is we are injecting it directly into the artery or vein. But what we need to do is we should use lignocaine, because rather than exogenous adrenaline, it is the endogenous adrenaline that will cause problem. What do I mean by that? The patient is in your dental clinic. The patient has a lot of endogenous catecholamines that are being pumped in the body because of the stress itself. You don't have to give adrenaline and the lignocaine. அவங்களோட பாடியில இருக்கிற அந்த endogenous adrenaline itself will cause problems. You understand, no? So the little amount, 1:1 lakh adrenaline that you have in your ampule or in your syringe will not cause anything. The one thing that you can do to avoid problems is aspirate. See whether you are in a vessel. If you're in a vessel, relocate your needle and deposit the solution. That's one point of care that you can do when you're injecting this thing. But I always use lignocaine with adrenaline. I don't use plain lignocaine, because I believe, or it is written in the book also, that endogenous catecholamines are much more dangerous than the exogenous catecholamine that we use. And the concentration that we use is just 1:1 lakh. So no problem. Yeah.
Thank you, ma'am. Any other questions from the participants? If they cannot unmute, they can put the question in the chat. Or they're finding it difficult to ask also, they can raise your hand. We can get the question from you. If there is no more question, we can call it a day. And any other questions for regarding Dr. Babyjohn's lecture also been presentation also, we can ask now.
Something related to the general practice, I don't think there is much questions about it unless we realize where we are. And
there should be too many questions also, sir.
I know, because of the Clinical Establishment Act and biomedical waste and all those things.
Sir.
Where somewhere at one point of time, all of us have to accept that we will have to have some standards now, henceforth. I know it is a burden for the beginners for giving 1,500 rupees or so for a biomedical waste where we segregate very less. Can we give LA with adrenaline for hypertension patients, ma'am?
Yes. So, yeah, thank you again for that
This is a
question,
good question.
Dr. Sarnan. Yes. So, hypertensive patients, again, you have to grade them, right? So, they will be on medication, their BP would be under control. So, it is indicated that you give plain lignocaine in hypertensive patients, but there's nothing wrong in giving LA with adrenaline, but do not give intravascular injection of the lignocaine with adrenaline. That's what I would say. Do it as infiltrations. You can give blocks, but if you're giving blocks, you have to aspirate. If you have plain lignocaine, you can give plain lignocaine. But again, in hypertensives also, you are not going to do a surgical procedure if your blood pressure is above 100, your diastolic is above 100, your systolic is above 140. So the grades of hypertension is there, no? So if it is controlled hypertension, controlled with medication, there's nothing wrong in giving lignocaine with adrenaline. Do not inject intravascularly. Is that okay?
I think the other common thing people should understand about anticoagulants that is commonly used. I think that we come across very frequently in our practice. I think all of us should come across. The moment we hear hypertension, we may think that it is under control, but you should always say, and nowadays these combination drugs are coming up with this antihypertensive plus anticoagulants, antiplatelets. So this is something which all of us have to know. Whenever they say they are under medication, do not take it lightly. At least ask them to get the drug name. And don't hesitate to see the Google. It's not that we can by heart all the trade names. I find that many people are shy of saying what the combination, or you just pretend as if you know the combination. But that is dangerous. So if you don't know the composition, you please you can open up the Google and, or at least you should ask the patient to wait outside. Then you can see what it is, check the BP, and then see what the combination is. So again, here I think she will highlight on to the anticoagulant, antiplatelet cases, what you should do. This is very commonly people say, don't know extra, go to the physician. Immediately hypertension, go to the physician. Yeah. See, we as a doctor should be able to understand the seriousness of these problems, what we face day to day. We cannot directly refer them to a physician. We should have the ability to know where we should and where we should not.
Yeah. So what we need to understand is the dignity of our profession. We should not give the impression to our medical colleagues that we are tooth doctors. We are not tooth doctors. We are doctors who are dealing with individuals or human beings who have problems in their teeth. Which means even you may be surprised, even our medical professionals do not understand that when we are doing a procedure in the oral cavity, we can affect the patient systemically. You understand, no? So when we send a reference saying that patient has to undergo a dental extraction, kindly assess whether the patient is fit for the procedure. They will write back saying the patient is fit for procedure, kindly go ahead. Okay, so that does not help. So we will be much more professional if we could discuss or write a letter saying that patient is to undergo a dental surgical or oral surgical procedure, for example, for a period of 30 minutes, which will involve surgical removal of this teeth. Like that, if we give them the time period of the procedure that is going, the amount of blood loss that may take place, and therefore the medical comorbidity that the patient is having, how will it affect the procedure that is going to be done in the dental clinic? Maybe that kind of a communication is better. That is one thing. Second thing is, when the patient is on an antiplatelet or an antiplatelet especially, you don't need to stop the drug. Antiplatelets, usually 3 to 5 days we stop it, no? Because of the lifespan of the platelets. But you don't need to stop, because by stopping the drug, it's not a problem for us. The patient will be affected. The patient can have an embolic phenomena, thromboembolic phenomena, which may cause a problem later on in life, right? So we are again professionals who are responsible. So the best thing is to do a platelet count, to do a, if the patient is on anticoagulants, do a prothrombin time, do an INR. If all this is within normal limits, you should know how many extraction procedures you can do, how much blood loss can be tolerated, and what kind of suturing can be done. Do you need to use styptics, or do you need to use an absorbent gel spawn or a Surgicel to control the bleeding and and therefore, and then keeping the patient for at least half an hour after the procedure, and then sending the patient. This is all responsibility from our side. So if the doctor who is referring also will understand, oh, I'm not dealing with a tooth doctor, but actually a doctor who knows what the physiology is and how it is going to affect. And we may educate our medical professionals also. Dentistry is not about drilling and filling alone, but it is more than that. Drilling and filling also will affect the, maybe the BP of the patient, the endogenous, endogenous hormones that are released in the patient. So that is very important for the patient, for us to understand as professionals. So we need to understand the difference between anticoagulants and antiplatelets. We need to understand what investigations we need to do before we go ahead and do the procedure, and how much of a procedure can be done for this particular patient when the prothrombin time and INR is so much. Yeah.
But then if you're doing a surgical procedure impaction or something else, you have to be a little cautious of all these things. So definitely
Then
know
you
the
need to
nature
stop.
then you need to
stop
stop
the drug.
It is not for a mobile, or maybe even for mobile teeth, it can be dangerous, but do not take it lightly. But do this test and have a record with you. So they will say what is the normal ratio. Then you can perform the procedure. In spite of that, inform them well in advance there will be an excessive bleeding. Even if you do a prophylaxis also, there will be excessive bleeding. Please inform that, write it in your prescription itself if you are not giving them the case sheet. Observe the patient after the procedure and send them, tell them post-operative, night you will have slight, blood tinged saliva and all those things, not to get alarmed. Only thing is it should not be clotting and coming out. That is what is there, and not to keep again back after going home. So these are some of the things which we should always learn rather than blindly sending them to a physician asking for their suggestion. This is for safeguarding ourselves. Tomorrow anything happens, we will say physician said, therefore I did. Let us not pass on the responsibility. We should also be responsible.
Yeah, there's a question on diastolic and systolic. Yeah, I would concentrate more on the diastolic pressure than the systolic. So if you have a diastolic of 100, then I would send him for a reference and get the BP lowered and then do a procedure. Yeah, and monitoring the patient while you're doing also is a good thing to do. While you're doing a procedure, after 10 minutes, you could check the pulse rate, and then if you want, you can check the BP if the patient has comorbidities. That's a good way of making sure that you don't have an emergency. There's a question for Babyjohn, sir.
One of the important aspects of practice management is work-life management, sir. Could you share your personal insight with decades of dental practice? I think if I
having a good wife.
So if I have to highlight on this, it will take some time, but still work-life management is very important nowadays. I would suggest that, because I find that this is always becomes an imbalance when you are committed too much. It can be in the form of financial commitment or family commitment or your work or administrative commitment. I belong to the last one. But then somewhere down the line, there is a time where we will have to really work hard when you are young and energetic during that particular period of time. But still, you have to have your own time at in a month or so. So there's a study which says that productivity increases when you work for 5 days and for 6 hours a day or something like that. So you'll be able to do a better quality of work, and your lifestyle also improves, and you get rejuvenated. Make it a point. You take off, you work for 5 days, and the weekends you see that you go out. Do not see that because you close, your patient goes to the next door. That means you don't have a confidence on yourself. Your patient will wait and they will come to you. That is what you'll have to gain in your life. May not be immediate, but at the long term. Then, as I tell you, please involve in the social activities. Like you can have at least a chat with your own fellow colleagues or some close friends in the evening to let out your stress on the day. So that should be there. And always go with the family out. So however you feel, or have a small walk. All these things will help you to rejuvenate yourself. And have some pets and hobbies. That's something which I follow. Have some natural visits of the forest or something, greeneries. I'm not telling you to go out for a tour abroad and all those things. That is not necessary. You have all these things as a part of your life. It makes you more interesting. Something new, you try to do it in your practice also. Whenever there is a new equipment or a new technique comes, try to learn that and try to do that. That gives you the thrush or a push so that it will be quite interesting. So you'll also update. So these are all the things which makes your life active. But of course, as age catches up, you'll have to spend more time for yourself and your family, and then try to reduce it. It's not that all through your life you can really work and make gain out of it, but you'll have to take care of your own self. Very important first, then the next after some time, right?
Call your teachers, call your seniors, call your colleagues, ask for help. There's nothing wrong with
Yes,
that.
that is
Nothing wrong
something
with that.
very important. Learn to say, I don't know. Please learn to say, I don't know. Can you tell me? This is something which all of us think that it is beyond our dignity, we lose our image. It's not so. By asking that, you will increase your respect. And they will be ready to help you out also. So that is something which most of us have to accept and learn.
Yeah.
So I think
is that enough, Dr.
I think one question is there, unanswered. I'm not sure whether oxygen cylinder is necessary in clinic setup or
Yeah, I said yes, it is. Yes, it is. Yes, it is.
sir, it is actually not expensive. The initial cost is only some 5,000 or 7,000 it will come. But then replenishing, because there will be some amount of leak in that. Definitely it will come down. So every day you are supposed to check it. And that is also a part of the Clinical Establishment Act, which better you have it or an ambu bag. See, these are all the things, very rarest of the rare moment, it may help you save a bigger problems. So this is not at all expensive, but these cylinders, maybe once in 2 or 3 months, you may have to change it if you are not using it. So, but then try to use it, open it and close it once a week, otherwise it becomes locked and hard. So that is something which you'll have to look after, because at time of emergency, you may not be able to open it. So that is, you'll have to see, that is why I'm telling you, never compromise on these things, small matters. Many times we do this mistake by compromising on the quality of the instrument or quality of the material, what we are giving by, few hundreds of rupees or maybe thousands. But that should go out of your mind. It's not that initially the amount what you collect for the beginners, it's the footfall that comes to your clinic is very, very important. And you don't expect all the patients, whoever is stepping into your clinic, should be converted as money. No. People will come and ask, then at the end of the day, they may not come. Do not get dejected, disappointed. You say what the truth is, be honest to the patient. Automatically, they will understand, okay, this man will say yes or no. And he is like this. So that is how you learn to bring develop your brand. Do not worry that nearby some clinic has started, immediately write a complaint or, see, these are all, those days are gone. Those days are over. And some people go and start the clinic in an adjacent to a very old practitioner who has got a long practice. This all shows your lack of confidence. The spillover will come to you, maybe. That spillovers are not the one which is permanent for you, and they will not be satisfied in whatever you give. He thinks that he is coming to help you for something. Just because there is a rush, they just walked in. So these are the things which you should eliminate from your mind, that under somebody place where some good practitioners there will start one or put a big hoarding all over the street. This shows your confidence limit. And then I told you the advertisements now to a level where we have stooped down is, I am ashamed to see some of the advertisement, but then I cannot directly put a case against them. But if it's really going on, I think people or associations has to write it. Only then the council will take an action, and we are sending a warning. More than that, if some things happen, we can go to a level of suspending them to a certain limit. But then ultimately we are into a balancing zone in the council, where we'll have to see on both the sides. As our colleagues also, we cannot let them out. At the same time, patients also, we'll have to help them out, and that is what most of the time we do. But there are times where sometimes we feel that our colleagues have not done the responsibility to punish them, but days are not long, because every month we are getting quite commonly such type of unethical advertisements and work, and the patient not getting informed, and all these things has to be stopped.
Yeah, there's a question actually which is not in the scope of this this talk, It's about including cosmetology, facial cosmetology.
Yeah, of course, since it is my topic you're asking, dental jurisprudence, I'm telling you very clearly, you cannot do dental oral cosmetology is different. Facial and hair transplant, you cannot do other than the oral surgeons as per the Dental Act right now, amendments. So they are the only qualified people to work on to the patient. But you can invite a consultant of maxillofacial surgeon, do it in your clinic. But if anything goes wrong and the consultant will be sitting on the chair and you may be doing the procedure, and the patient will definitely say he did not do, only this person has done, and you will be in a soup. So that is where you'll have to be unnecessarily you are getting into problems, and do not expect your association or your colleagues to come and save you. Time have crossed that those days, so be careful.
Yeah. So is that okay?
Yeah, you want to ask a question, Dr. Felicia Parsi? Anybody having a question? Yes, please. In the chat box, somebody has asked whether you have to have tracheostomy kit in your clinic. I don't think.
No, you don't have to. If you have the airway, that is enough. If you want, I showed you the way the airway. It's very easy to put the airway in, also the oropharyngeal airway. You don't even have to have the nasopharyngeal airway. Oropharyngeal airway mattume irunda. It's 200 rupees or something. You need to put the concave part towards the palate when you're and then turn it around and put the concave part downwards. So basically, you're bringing your tongue forward, opening up the posterior pharyngeal airway so that the oxygen goes in when you're doing your either administering through the face mask or doing a mouth-to-mouth resuscitation. Yeah, you don't need to have a tracheostomy kit.
Thank you, ma'am. Thank you, ma'am.
Yeah, thank you so much, Felcia.
Good evening, ma'am. I'm Dashni, ma'am. How are you, sir? How are you, ma'am?
Hi, Dr.
I'm seeing all
Dashni.
my alumnus also here. Good, nice.
Thank you, sir.
Nice to see
Thank
you.
you, sir.
Please attend all the CPD's professional development. Now we are going to make it mandatory for the next renewal onwards in the council also.
Okay,
Because
sir.
this is
Thank you,
something
sir.
which people are not getting updated in the skill and the knowledge, which is causing a lot of problem for us. So
Yes, sir.
maybe shortly, I think probably they'll be bringing in the rule. If not all over India, at least in Tamil Nadu.
We are eagerly waiting, sir, again. Thank you, sir. Thank you, ma'am.
Thank you, man. Our profession is a dignified profession and we should maintain our dignity. Yeah, together.
Yes, ma'am. Yes, ma'am. Thank you, ma'am.
Yeah, thank you.
Okay, sir. Shall we?
Yes,
close?
if there is no more question, or if there is still any question, you can ask in the group. We can again go back to sir. I'll go back to him personally and disturb him to get the answers from him and madam. So
There's
no
a book I told you, which is still how to set up the clinic also in my book. I have told the diagram, the drainage, how to keep the ventilation, all those things. It's for the beginners. So it will help them. If they want, they can go to the Amazon and purchase that now also. That will give up for beginners.
Yes, sir. I'll put it in the group also, sir.
Yes, sir. Thank you so much.
Thank you.
But the patient says the heart is like chest is paining after giving local anesthesia. The doctor is going to get a tachycardia and a slight heart attack. That's the scenario now. Now, as we are ready with the emergency setup and all that, the emergency ceases to exist. Exist, as you said. So thank you so much, ma'am, for the wonderful lecture, and sir also for sacrificing your personal family time for the dentist family, sir. Thank you so much. Really a great time, great Sunday evening, sir. Thank you so much, sir and madam. Thank you all the
Thank you so
participants
much.
also. Thank
Thank
you
you
so
so much.
Thank you.
Thank you so much,
Thank you, Dr.
Dr. Monica Vasagam, Dr. Babyjohn, and Dr. Mrs. Babyjohn.
Thank
Thank you so much.
Thank you.
Okay.
See you all in the next webinar. Thank you so much.
Thank you. Bye.
Bye-bye.